I come to you with problems that I hope one day you will all have solutions for. So I am a paediatrician, and I have spent many years looking after babies. And I just want to tell you a bit of the journey that I've been on from COP to code and back again, and where we're going from here with some of the collaborators I have in this room. And I guess first thing I need to say is that there are going to be some pictures of babies who are a bit poorly. So if any of you feel a bit uncertain about that, feel free to step up and at any point and come back in afterwards. So I started my undergraduate degree in physiology and pharmacology quite a long time ago now. And in my neuroscience modules, I became quite interested in pain. And and I was always quite interested in working with children ever since I was a school-age person. But the kind of question that came to me and my mind at that point was, do babies feel pain? Now, intuitively, as a human, as a parent, we would probably all assume yes. But the reality was that until the 80s, so not that long ago, babies underwent surgery without any pain relief, right? At the time, standard anaesthetic practice for babies was just nitrous oxide, so not even the anaesthesia that we're used to now, okay? A clinical trial started by just trying morphine for these babies who were undergoing surgery. And overnight, they saw a reduction in mortality and morbidity, and that just changed the practice. By the time I was kind of submitting my doctorate, the James Lind Alliance, so this is a UK-based organisation that looks at setting priorities in clinical research. And the one that came out for preterm birth, in their top 10 list was this one, which is, what is the best way to judge whether a premature baby is feeling pain? Yeah? So how can we do that? We can't ask them, and they can't tell us. So we're going to be using objective measures. We're going to be using data. We're going to be using everything you guys are very comfortable with. But then a few years ago, it flipped, and I suddenly saw it from the other side. And this is my son, who spent some time in the neonatal unit. Okay? So instead of me looking after other babies, I was being looked after by my colleagues. But let's take it back a bit and look at the brain. I know a lot of you in here look at single cells, some of you using models of neural networks, but I don't see it that way. I see it as a whole brain. I see it as a person. And this is a model of a 29-week gestation baby. Okay? It's not actually that premature. So at 22 weeks gestation is at the moment the limit of viability. And there are some centres globally that are trying 20 weeks. But that's all of this time is a very grey area in terms of survival. Bring it up to term, so when a baby's born, you can see it looks like much more like a normal brain now. Yeah? But actually, it isn't until 30 weeks gestation that the thalamocortical connections actually develop. And if you look back even more, it isn't until 24 weeks gestation that actually synapses start forming. So a baby could be born and survive that premature that their nervous system isn't even developed yet. And then we come up to the adult, and we all know that it isn't until our 20s that we stop doing stupid things, right? So the neonatal intensive care unit is very challenging for vulnerable brains, okay? And we do a lot of pretty invasive things to keep these babies alive. We put tubes in their mouth, into their lungs. We've got arterial lines going in through their umbilical cord. We're taking daily, sometimes 6, 7 times a day, blood sampling to actually look after these babies. But then how do we look at it? So I, across my time in neonatal research, look at adversity now, early life adversity. And I split this into threat or deprivation. So threat being things that can cause harm to that baby. And those are things like too much noise, too much light, painful procedures, we don't let them sleep. All of these things that actually this baby shouldn't be experiencing at any point. They should be in the womb. And deprivation. We take them away from their caregivers. They're in an incubator. There's not really, there's that separation. There's that kind of lack of serve and return, that attunement between a caregiver and a parent. So what do we have? We've got babies who are stressed. We've got them over here who are in that incubator and away from their caregiver. We're doing procedures. So the middle picture is a lumbar puncture, looking for infection, meningitis. And we're doing blood tests to check for many different things. But what is our aim? What is our goal? We cannot stop these babies from actually experiencing this stress. But can we find a way to make it predictable, to make it controlled, to make it moderate, and can we respond to it in the hope that when these babies graduate neonatal care, that they're resilient? So, the code. We've talked about the problem. This was when I started my journey. This was the kind of solution I went on. And I said it wasn't until the 80s that, you know, we started giving analgesics to neonates. Okay? It wasn't until 2006 which we've actually discovered that the brain actually did anything to a painful procedure. Using near-infrared spectroscopy, you did a blood test on the heel of the foot and the contralateral side of the brain lit up. Most of our pain scales are very objective. We look at their face, but babies cry at anything. Yeah? Hungry, need a change, pain. So can we see that the brain lit up in response to those facial expressions? And it does, it correlates. Analgesics in neonatal care is still pretty rudimentary. We tend to use morphine to sedate rather than analgesics. We very rarely use paracetamol. Culture is changing. It's just slow to change. Sucrose, so sweet solutions, is one of the things we give and has been warranted as an analgesic for many years. But in reality, it's a comfort measure. And when we looked at the near-infrared to facial expression, we could see that even those that didn't evoke a facial expression, those babies that you would assume wouldn't be feeling in pain, more than 3/4 of them actually had a neural response to it. So who are we treating? Are we treating ourselves as the caregivers, or are we treating the babies? So moving on from near-infrared, going on to the EEG. And it was the first time that we started looking at finding a template, a 500 millisecond template. And then thinking we had a biomarker at the time, could we actually use this to make some changes? Could we actually do some interventions? But what we did find actually was that it was very difficult for that early primitive brain, I suppose, to distinguish between different kind of stimuli. And prior to 35 weeks gestation, that baby would still be responding in a delta flash, a very big burst of activity. And it wasn't until 35 to 37 weeks, so very nearly term, that you could see separations in the EEG from pain and touch. Heel pricks are just one of those kind of ways of doing blood tests. How do we, in the real world, the messy world of the ward, do we actually start looking at other procedures, lumbar punctures, cannulations, those kind of things? So again, we've got another problem. We've got a biomarker. How do we put that into other different aspects of things? A high-speed video was put in to try and find and time lock the first point at which a needle went through the skin. Painstaking process. And then we eventually were able to put babies into the MRI scanner. Now that was a logistical nightmare, but we did it. Yeah? And then we were able to perform noxious experimental stimuli, so pinprick procedures to them. We compared a term baby to an adult, and what we see is that of the 20 areas in an adult, 18 of those lit up under fMRI. Okay? So this idea that babies don't feel pain, to some extent is true because they can't tell us they're in pain, but their brain has the capacity to experience it. We were able to use these templates to show that by putting topical local anaesthetic on the skin, those markers actually reduce. So have we suddenly got a potential biomarker that we can go for? But then when we put it into other contexts, so this one was actually a trial of morphine that we did for retinopathy of prematurity screening. So this is quite an invasive monitoring procedure where the baby is held quite still, the eyelids are open, and the ophthalmologist will touch the eyeball to look at the back of the retina. These babies, we know, for days after this procedure, are physiologically unstable. We basically put them in a dark room, we don't touch them, and just let them recover themselves. Problem is that when we gave morphine, gold standard pain relief, we had to stop the trial early because it caused more respiratory problems in these babies than it did. So if our gold standard analgesic doesn't work in this population, what do we have? So we went back to the basics. We went back to the drawing board and we looked at affective touch, the activation of C-tactile fibers. And actually, does stroking the area of skin have an effect? And experimentally it does. We used a brush. We stroked the leg of the baby that was going to have the heel lumpers. And we saw a reduction in those templates. But the clinical trial we just did, where researchers were the ones that taught parents what to do, failed. So this is the back again. We took those models and we've put it back into the clinic in clinical trials. So this was a multi-center study that had 112 babies in it. And from a baby point of view, we show no difference in that kind of effect of the stroking in terms of it. What we did see, though, was that the parents felt really empowered by a study like this, being involved in their care. So that idea of separation is something we shouldn't be continuing. So we're here in 2025 again. And the James Lind Alliance has done an update again to kind of premature babies and what we should be doing. And in the top 10 priority is what's the best way to manage pain and distress in these babies. So in the 15 years I've been in this area, it feels like we haven't done much. So we're back to the cot again. What are we going to do? But we are in 2025, and AI is the buzzword for everybody, right? And the Health Foundation, in the UK anyway, has come up with 6 priorities for AI use in healthcare. And I'm going to touch on just a few of them and point out that number 1, number 2, and number 6 are really important for you guys to understand as well. But you need to talk to us. Like I said, I've got problems. You've got solutions. We can't just take your solutions and put it into real life. We need to work together to adapt it. We need the things I see on my monitor are the ones I'm going to be using every day. I need you to use what I use. I need you to give me tools that I can use that do not add to my clinical workload. And we need to find ways of actually teaching us how to use it in real life. So something that's come up in the past 15 years is that we shouldn't be looking at single events anymore. So nearly every study that I've done has been looking at heel lancers or lumbar punctures. So single events. And what we see is something very transient. In the EEG, we see it kind of milliseconds. But For me, as a clinician now, I want to look at that entire neonatal journey. I want to see the changes that happen over time. And this is where some of my collaborators in Exeter, Mark and Dom, we're trying to look into that now. And we're about to start 2 different projects. One, the Digital Twin project, which is to try and find those biomarkers, map those biomarkers during gestational development, and see if we can predict outcomes later on in life. And 2, we need to keep trying interventions. There is such a long lead-in time from kind of finding those biomarkers to actually doing anything. And one of the things that's come out, which may feel very, very simple, is music. And so we're about to just try music to see if babies can sleep better. They should be asleep 80+% of the time. So we want to know whether actually we can see any difference. So you'll be pleased to know that my son is now 3 and he's doing very well. And I just want to say thanks to everyone that's helped me get here. Still feel like an imposter in a maths institute. So Mark and Dom, who I'm currently working with. Our neonatal unit is really, really impressive from a neurodevelopmental care point of view. And from my team in Oxford, who taught me and was very formative in my youth. Thank you.
Thanks very much, Ravi. I think you were the first.
Yeah, thank you. Very, very good talk. Thank you very much. I have a question also for Michel, in fact. The alpha rhythm is related to pain. So can we use the hair plug for the babies to monitor, to assess the pain? Because the alpha increase or decrease if you are in pain.
Babies don't have alpha.
They don't?
You don't have alpha until 1 year old.
Yeah.
Sorry. Thanks.
But they have some. My question for Michelle was, how small can we make these in-ear devices?
Yeah.
It's difficult. I think we can work hard and change
After, I think...
I come with hard problems.
term, I think it would be extremely
You think it's possible or not possible? Not possible, okay.
No.
We need other, yeah. Yeah, sure. Oh, sorry.
There's so many non-invasive sensors that are being developed now. I wonder whether those have potential to be useful information. I mean, I'm thinking about under the mattress sensors, which can pick up heart rate and respiration in adults, and about preterm infants. Radar sensors inside, you know. So I can see that. Well, I don't know. It's rather alarming seeing so many sensors on these babies.
Yeah, so I agree with the radar thing, and I think that's something that's really interesting because it is so non-invasive. You can literally just put it on top of the incubator and can look down on it. I think there's a load of potential there, and our collaborators in Bristol are looking into that at the moment. In terms of other monitoring and under mattress things, heart rate, you've got actual heart rate ECG monitoring on them. We don't need to necessarily have things underneath. But I agree, looking at something more non-invasive is going to be a really big way forward. I like the idea of that, but again, of radar. But the thing about all of these is that we don't have any neurological measures of it. And at the moment, from a kind of neurological perspective, we have ultrasound, so cranial ultrasound, because babies have a window to their head, so we can put an ultrasound there, or they've got MRI scans, both of which are not functional, are anatomical. Putting babies for a functional MRI is a logistical nightmare, and would never do it in the NHS, right? And so actually, is there a functional way to look at it? Near-infrared was one of them. The Cambridge UCL got a lot of doing the Doppler stuff, which is really interesting. EEG is the most obvious.
Thank you for the talk. I was intrigued by the logic of the stroking study. Why would you expect that C fiber would be analgesic? It would work for stress. It would work on the affective component of pain, not on the discriminative aspect of pain, which has different roots. So it's not surprising that it would make them more. It would be a comfort intervention. You use the word comfort,
Yeah.
not actually a pain, not actually analgesia. So
yeah, so I guess that's how you define analgesic, right? And if you think of it as just a drug or that would have an analgesic effect, then it's not that. But if you go back to kind of nervous system, like very simple anatomy, C tactile fibers are faster than unmyelinated C fibers. Okay, so by by stroking, you're activating those, so there's the same path as getting to the spinal cord quicker.
C fibers are faster.
No, they're slower. No, unmyelinated is slower, and C tactile fibers are ever so slightly faster. Did I say it the wrong way around?
No, you said they're faster than myelinated, but the sensory the A deltas are much faster, which are myelinated, and they are the ones that enter the insulin.
Yes, but nociception is done through the unmyelinated C fiber. So painful response.
Let's do it offline then.
Yeah.
Any question at the back there?
Hey, hello. Good talk. I do have a few questions. So I work in pediatric anesthesia as well. We're collaborating with the hospital doing this kind of stuff. And what we do is basically we attach an EEG sensor to the children while during anesthesia, and we basically record the signal throughout the entirety of the surgery. I focus on emergence. And during emergence, one of the things that we want to manage is nociceptive reaction. And through our analysis, we haven't been able to find any precursors from EEG of said nociceptive reactions. But I saw on your slide that you said that you've seen evoked potentials which are generated by nociceptive reaction. May I ask what features are you looking at on the EEG? Because we haven't been able to detect it.
Yeah, I mean that's probably beyond this. We could talk afterwards. So my PhD was in pediatric anesthesia, and where we looked at nociceptive reactions to under anesthesia.
Right.
So we can talk about that. Yeah.
Okay.
So, but we're looking at the same template and for the same template. But whilst the template wasn't necessarily there, what we did see was a shift in the power spectrum, and kind of conclusions from that were very much like actually for the same gestation of child, we didn't necessarily see a nociceptive response from the template, but we saw a distinct difference in their power spectrum. So actually, were they potentially more anaesthetized being born prematurely than non-prematurely born?
Okay, so what difference do you see exactly on the power spectrum? Like a difference in the power ratios between certain bands, or what?
So I have to look it up because it was in 2014, and so I can't remember off the top of my head. And so we can talk about it and look it up.
And just one last question: how much lead time do you see from these features versus the nociceptive reaction itself?
500 milliseconds in the test.
Very short. Yeah. Okay. Thanks.
Thank you. I don't know if you are aware that I have some collaborators in Lyon who have been in France who have been working with the hospital and the related problem of determining during births, during difficult births, let's say, the baby has some pains and trying to use that to decide if you do a cesarean or not. And they were basically monitoring the heart rate and applying multifactor analysis, a little bit related to what Jean-Marc was mentioning this morning. And from this multifactor analysis, they were kind of deciding whether there was actually some stress, meaning some pain in the baby. So don't know if you're aware of that or if they could be related with.
So am I aware? Yeah, heart rate variability has been used a lot in terms of kind of research and stress in terms of that. But the heart rate variability in itself is not necessarily to do with pain, right? It's very tricky, different things to tease out. Okay.
Francesco?
It was great. Thank you very much. I've got a comment and then a question, right? So the comment is, it's really interesting to look at this because, you know, it can be translated, I think, also for people with dementia who have got impossibility, well, they've got reduced language abilities. And often the stress and the aggression observed, you know, it's argued it could be due to pain because there are comorbidities that are there. And you know, the clinical practice is really to use neuroleptics every time these patients express aggression. And well, actually, probably what you should be doing is, you know, giving analgesics or things like that, right? So actually having a mean to detect that without having a person being capable to verbalize it would be very useful. So maybe we can chat about that later on. The other question is, since we're talking about non-invasiveness, have you ever considered looking at transcranial magnetic stimulation for, you know, using analgesia on these kids? Is it even possible?
No.
Like it's not
I don't
possible?
think anyone would let you do it.
Okay. Why that? Why is that?
Well, it's not the easiest thing to do. Neonatal units are very small, and I'm not sure parents would actually let us do it. I mean, to try and get the numbers to do a study like this, you're probably looking at a success rate and consent of about 50%.
It's weird though, because then they accept, you know, the opioid, but they don't.
But I guess that's the thing, is that we do that under the guise of medical practice. Nearly I'd say fewer than 5% of drugs we use in the neonatal period are actually licensed for neonates, because drug companies just don't test them. Because one, there aren't routine the usual biomarkers to test them, and two, no drug company is going to go on a fishing expedition. So we actually prescribe everything off license in this population.
Is TMS used for pain relief?
Yes, but chronic pain mostly.
Yeah.
I mean, people hasn't really looked into acute pain because there are other means in the adult which are much more effective. But since these kids don't seem to respond to opioids, or they can't get what adults usually get, I was wondering.
Well, they might respond to opioids from a pain point of view. They have quite significant side effects, at which point we need to then control their breathing. So actually, we don't know.
Okay.
But is there scope?
Huh?
Is there scope?
Well,
it's soft, isn't it?
the modulation to the electric field would be very different.
So,
I suppose, or the magnetic field. The back there. Yeah.
Really enjoyed your talk. In adults, perception of pain changes across the 24-hour cycle. And in the neonatal unit, as you pointed out, there's lots of noise. There's no proper light-dark cycle normally. And we know that infants don't have a properly organized circadian system. That doesn't develop for several months. So I'm wondering if intervening with some light-dark cycle method to synchronize the infants better to an external signal could also improve how you might manage pain in infants.
Absolutely. And actually, clinically, we do try and have light and dark, because I know they don't have a circadian rhythm as such developing for months down the line. But we do try and do it and then train them accordingly. And they should be asleep the vast majority of the time. Even in daytime hours, when we have lights on, they will have covers over their incubators, so their incubators are dark, because they shouldn't be exposed to it at that earlier gestation. So yes, I agree that we need to be doing that. And I've forgotten the other half of your comment now.
Sorry?
I've forgotten the other half of your
I'm wondering, you were kind of highlighting the challenges of both detecting pain as well as managing pain.
Yeah.
I'm wondering, well, I have a second question to that, but perhaps having better management of the environment might facilitate that.
Yeah.
One thing I did wonder is how do you titrate the dose? Because as you said, the drugs have been tested for ED50s, etc., on humans, adult humans. How do you downscale that?
I don't know. It's just in the formula. But I don't know how they've done it, whether they've just extrapolated it and gone downwards.
So there are guidelines though for
Yeah.
paracetamol and, or do you use morphine?
Yeah, you use it for sedation.
Yeah. Good. Yep.
Yeah, thank you for the talk. It was very distressing. It was very interesting. The question you asked in the middle, do babies feel pain? What's the consensus on that nowadays, and is there any kind of rigorous evidence to suggest that they don't?
I would say people would assume they do feel pain.
Yeah, sure.
The truth is, clinically, is that often we still do procedures without appropriate analgesic. Sucrose is still ubiquitous and is used all the time. When a Cochrane review that came out, it was like the minimal effective dose of it was only 2 milliliters. Yet sometimes they're getting tens of mils of it, and the long-term effects of too much sugar is quite dramatic as well. So do babies feel pain? I think everyone would say yes. Do we do anything about it?
I just want to, I know you're gonna chat about exactly what the EEG marker of pain is offline, but is this definitive? Like, do we know that this EEG marker is a marker of pain? Is it validated? Okay.
No, I think in the early days when we started out, we definitely thought this was a nociceptive specific response. But the truth is, it's probably an alerting response. It's just over the central electrodes, oversees it, and we see it from in nearly every type of stimuli that we have, but to a greater extent the noxious stimuli, and to a greater extent the more invasive stimuli. So there is a graded response to it. So I'm not sure you can be as specific as saying it's a pain-specific response. But as I alluded to, I'm moving away personally from single events. I don't believe that is actually the useful factor, and looking at a much more longitudinal aspect of it is the way.
I think this is quite interesting in the context of the whole meeting, just in terms of the problems that we do have validating some of these ideas. So, for example, yeah, maybe we could test TMS or investigate the use of TMS for analgesia in infants, but we might never be able to validate it, or, well, at least using current technology. Yeah.
Sorry, this is kind of more of a philosophical, societal question, right? Because, we've said, okay, so the consensus is kids feel, well, preterm babies feel pain, right? But we are not doing anything about it, or we're not doing enough about it. So how's that possible? Like, how's that even legal? What is your take on this?
So I think the hardest thing in neonatal care is culture change. And whilst there's a lot of studies, a lot of evidence out there now, actually implementing the science is really difficult, and getting staff on board is really difficult. And we're fortunate where we are that we have a very progressive neonatal unit from the nursing staff, from other healthcare professionals, from the doctors, that actually want to change practice. That is not the case everywhere, and people are very stuck in the ways of that they learned when they were a student. And actually to try and change culture is a whole different type of science. Implementation science is a whole different science, and it's really tricky to understand the barriers of why people don't change.
Maybe driven by the fact that a child doesn't vote, doesn't have the ability to complain, doesn't have the ability to make a whole fuss about
if you want to go down that route,
right?
The amount of money spent in paediatric research compared to anything else is significantly less. So it's a big problem, because we're scrabbling for kind of the resources to do these studies, and that's why we end up extrapolating from older children or adult studies.
Oh, this is very interesting. Thanks.
Do you think it's a matter of shame as well? I mean, if you're coming to these clinicians saying, these babies are feeling pain, but no one's doing anything about it, they're going to push back because then they have to reckon with the fact that they're not treating the pain. Have you seen that kind of, do you think that's part of the reason why people are not interested in looking at this?
I mean, it's a really interesting comment. That shame is really interesting. And I suppose that could be an element of that. I don't know if that's the way. So the way I've trained in paediatrics is very different to, say, even some of the London trainees have trained in paediatrics, because we're in a unit that is very all-encompassing and family-orientated. When we do procedures, parents are there. When we do some procedures, they are on the parent while we do it. So actually, the whole family unit is a big aspect. So for me, I trained in that environment. I am not scared of a parent being around. It's interesting because when you move to a paediatric ward, you would never not have a parent around. So why in the neonatal unit do you tell them to go away? But people do, and some of my older colleagues, they still are very much like, you don't want to see this. It's going to be really distressing for you. You don't want to see this. But what we know is that parents who then go home after a significant amount of time in a neonatal unit suddenly do not know how to look after their baby. So their child who suddenly falls over and gets a cut, they are themselves suddenly really upset, and kind of they don't know. They have never had that serve and return with their child. They have never been there to comfort their child. So actually, suddenly you're let go. You don't have any support. So a huge amount of the work we do in neonatal units is actually to support a family, not just look after the baby. So that whole idea of deprivation is big. It's really big. And these kind of awards that we've got in our unit is around keeping that family unit together, because it's all well and good getting these babies to survive. It's actually how do you make them thrive later on.
So, sorry if you answer already to this question, but do we know that there is some consequence of this trauma at school? Do we have some indication that there is consequences? Or?
Yeah, it's a good question. And simple answer, yes. There are problems later on. And the more extreme preterm you go, the more you see like physiological, psychological problems. So cerebral palsy is the obvious one that comes through. But even the moderate to late preterms, where we don't do much intervention, we don't need much to keep them alive. They're just born smaller and younger, so they just need time to learn how to feed and grow. They actually constitute over 80% of admissions to a neonatal unit. And whilst they don't need such intensive care, their sheer numbers in the UK anyway is over 2 billion per annum. And actually they have a significant knock-on effect in their educational attainment and neurodevelopmental conditions. So autism, ADHD particularly, is associated with being born preterm. So actually later on in life they have significant problems, even though physically they are fine.
Okay, brilliant. Thank you very much, Ravi.